All right, so now we begin the discussion of the assessment management of patients with diabetes. So, basically, diabetes is a group of diseases that are characterized by hyperglycemia. I emphasize characterized, that's not the problem. So, that's part of the diagnostic of, excuse me, of diabetes. That hyperglycemia could be the result of defects in insulin secretion, alterations in insulin action, or both. And also it could be what's not listed but implied is the effect or response the organs make to the insulin that is produced. Generally, it affects about 25.8 million people in the United States, and a third of all cases are undiagnosed, so that number is potentially even higher. There are 382 million cases worldwide. That's as of 2013, and it's projected by 2035 there'll be almost 600 million cases by 2035, which is a huge growth of a condition, some of which is preventable or treatable, as we'll discuss as we move on. And as you can see, prevalence is increasing. Now, one of the things that is true is that we know is minority populations and older adults are disproportionately affected. There's a lot of speculation and potential contributing factors that make this true. Many of those are related to the various social determinants of health. So access to quality food, access to safe environments where people feel that they can exercise, access to potential physical activity that's beneficial, access to adequate or sufficient health care, or even preventative or proactive health care. And that could be that the health care is there, they can't get to it, as in transportation. Think about homebound adults, older adults, or perhaps there's not healthcare, preventative type healthcare or proactive healthcare in the areas where these populations live. So I'm not trying to identify any specific minority population here, and that's going to vary from area to area. Diabetes is diagnosed by the presence of symptoms plus an alteration in glucose. So I say that strategically because there are a couple of ways testing can be done. And actually, you'll see here there are 4 ways that testing can be evaluated to be indicative or help be diagnostic of diabetes. So one of the ways this presents is a patient comes to the doctor and they've got a cut or a wound that just is not healing up. Or they report a symptom, my vision is funny, my feet are tingling, there's no other explanation, they rule out other causes, for example. Those are all ways, and you'll see later the symptom of diabetes is pretty broad. There are lots of things that can be early manifestations of diabetes, so a whole cacophony of symptoms that could potentially be associated with diabetes, and you'll understand why as we get through this content. But the patient shows up and reports some symptom that could be consistent with diagnosis, and then we do a random glucose. If the random glucose is greater than 200, then that could be indicative. If they've been fasting, then the parameter is 126. So a fasting glucose greater than 126 could be indicative of diabetes. So it could be both of these. You can do multiple tests to help be confirmative in your diagnosis, or they could be done individually. Another example is the patient presents with a symptom and there is, for some reason, a hemoglobin A1C has been done and it's greater than 6.5. This is an important distinction here. Diagnosis is made at 6.5 or greater. Management of diabetes is a different value. So right now we're talking about the diagnosis of diabetes. So if someone has a hemoglobin of A1C of 6.5 or greater, that together with a symptom can be diagnostic. Another option is a 2-hour plasma glucose test of 200 millimeters of mercury. And this is basically a glucose tolerance test. So the individual comes in fasting or they've consumed a prescribed dosage of glucose. Usually this is a drink that a physician provides, or so you could take that drink and then come in for the test, or you could be in the office and have this done, and then 2 hours later have glucose done. If the glucose is greater than 200, then that's diagnostic. And you can see a similarity between the 2-hour plasma glucose and a random glucose of 200. You can see the similarities in that parameter. Now, to illustrate how these might be used together to be confirmatory or rule out a diagnosis, so someone could come in and maybe they do not have any symptoms associated with diabetes, or perhaps they do, and their physician orders standard chemistry for a yearly visit, and maybe the individual's fasting, or maybe it's random, but they get, let's say, a fasting glucose of 127, 128. So for some reason it's higher than 126. Then the physician's like, that's kind of got my attention. Let's do a hemoglobin A1C and see where that is. So then the patient has blood drawn and a hemoglobin A1C is run, and the hemoglobin A1C is 5. Then that would preclude the diagnosis of diabetes. Now let's talk a little bit before we move on about the differences between these tests and what they're telling us. So a random glucose is just a glucose that's drawn anytime, regardless whether the individual's fasting or fed. So if a glucose in a fed state, if you've had breakfast or whatever, your glucose should never be over 200 unless you have diabetes. Your glucose may go up in response to what we consume, but in a fed state, it shouldn't exceed 200. The same is true for your 2-hour plasma glucose of your glucose tolerance test. If we give you a big dose of glucose, your body should still be able to adapt, secrete insulin, and mitigate whatever glucose you've got enough that you don't go over 200. So that's what that test is. Those tests are doing. That's what they tell us, is that when we put glucose in this system, that it goes up. Now, when we're fasting on a day-to-day basis, or even between meals, when we're fasting, our glucose should have a lower high limit, that being 126. We usually run in the say 80 to 125 range. Some people may have a sensitivity to when their glucose is in the lower range and they have symptoms. You may have heard of people who report hypoglycemia, and that just may mean that they have a little more insulin secretion than some of the rest of us that metabolizes some of that glucose, moves it into the cell to a lower level, and they may need to eat in order to boost that. When they do, it shouldn't exceed 200, and when they're fasting, it should still be less than 100. The rest of us should still be less than 126. So the fasting plasma glucose tells us in a fasting state that our glucose is in less than 126, somewhere in that 80 to 120 kind of range. That's where we maintain, and that's what we would expect in a fasting state, our sugar to be, somewhere in that area. Now, that is just for that period of time. Obviously, as soon as the person eats that day, those numbers are going to change. So that is for that day, and it could be different today than it is tomorrow. So a fasting plasma glucose is for that moment in time. Now, hemoglobin A1C is different than the other 3 tests here. The hemoglobin A1C is actually literally a glycosylated hemoglobin A1. So what that means is that is the amount of glucose that is adhered to hemoglobin molecules. That test is a test assesses the glycosylation of hemoglobin over a period of time. That process is not an instantaneous event. It doesn't change when we eat. It doesn't change when we fast. It evolves over time. So that is roughly a 3-month process that evolves to glycosylate hemoglobin. That's a normal biologic process, but if the hemoglobin is excessively glycosylated, in other words, it's high, greater than 6.5, that means that over the past 3 months, this person has been consistently having sugars greater than 200 in a fed state and greater than 126 in a fasting state, because that excess sugar is attempting to bind to hemoglobin. So that's what is meant by that. Now, this slide is just to kind of give you an overview of the general types of hemoglobin or diabetes, their range, where they're going to show up with a normal glucose tolerance test, what we refer to as pre-diabetes, what would be indicative of that, and then also what would be diagnostic for diabetes. Notice that pre-diabetes and diabetes, both patients are hyperglycemic. The severity of hyperglycemia varies with those different conditions and the severity of the diabetes. So there's a difference between type 1 and type 2, and we'll talk about those because we're going to delineate those specific conditions as we go further. There are some other specific subtypes of diabetes that we're not going to get into detail about. That would require more time than we have to cover this content. Gestational diabetes is touched on. I'm sure Ms. Dover will cover this some in the obstetrics portion. This is a type of diabetes that can evolve during pregnancy and can persist after pregnancy in some populations. And as we start talking about type 1 diabetes, it may make sense why that happens. So in the bottom section, what you have is what the fasting plasma glucose would be, what a 2-hour plasma glucose, that's the 2-hour tolerance test, the glucose tolerance test I was referring to, and then the range for hemoglobin A1C in each of these states. So if a patient, an individual, even if they're predisposed to type 1, perhaps they may be a risk for type 2 or one of these other conditions. In normal glucose tolerance, you can see what the fasting plasma glucose here, less than 5.6 millimoles per liter. What you're going to reference is the 100 milligrams per deciliter, or as I mentioned earlier, 126 is kind of the cutoff. Well, excuse me. Let me just be more clear. So normal glucose tolerance is going to be in a fasting state around 100 or less milligrams per deciliter. A 2-hour response is around 140 milligrams per deciliter. It doesn't have to be right on that, just in that neighborhood. And then hemoglobin C would be less than 5.6. That would be a normal response to glucose. Now, if someone is at risk for developing or has a predisposition to developing diabetes, and we're concerned that they may be manifesting what you'll hear people discussing as prediabetes, then when they have these tests done, we would expect to see, again, prediabetes, a glucose in the fasting plasma glucose in the 100 to 125 range, so higher end of normal. And then the 2-hour glucose tolerance test, 2-hour plasma glucose, is 140 to 199. So coming up to those earmarks of 126 and 200, approaching that, but not there yet. That's what we mean by prediabetes. And of course, the more of these that are in this range, the more confirmatory it is as a predictor for the development of diabetes. Hemoglobin A1C is going to be in the 5.7 to 6.4 range for these pre-diabetic patients. And then you can see, as I mentioned earlier, the parameters for the full-on manifestation. So in the pre-diabetes state, there's we have a difficulty managing glucose. Perhaps some dietary interventions and lifestyle interventions like exercise could preempt the evolution of diabetes and the need for either insulin or some kind of glucose lowering agent. Again, depending on the type of diabetes, and that'll be clear later on in class. But you can see when we move into the diabetes range is when we see that 126 milligrams per deciliter on a fasting test, 200 milligrams per deciliter on a 2-hour glucose tolerance test, and a hemoglobin A1C of 6.5 or greater. Now, some of the predisposing factors, risk factors for developing diabetes: family history. There is a genetic component, particularly to type 1 diabetes. We're continuing to learn about type 2 diabetes. There may be some genetic components there. I'm sure during your lifetime as nurses, during your professional career, there's going to be more manifested about these different, a variety of conditions, specifically diabetes, as well as these other endocrine issues, where you'll see more and more genetic associations with different conditions. But we do know that a BMI of greater than 25 kilograms per meter squared is a risk factor for the development specifically of type 2 diabetes. And it does, it may contribute to the manifestation of type 1. Notice I used the development of type 2 diabetes and the manifestation of type 1. That'll make more sense in a little bit. Physical activity also contributes is considered a risk factor. And then African American, Latino, Native American, Asian American, Pacific Islander. This is just referencing the minority populations that I alluded to earlier. That I alluded to in the obesity lecture. These are the minority populations specifically that have an increased risk for developing diabetes. Again, not necessarily because of weight. There could be dietary factors that are similar. I'm not trying to say that these minorities have more likelihood of being overweight. What I'm just saying here is that these minorities are considered a risk factor for the development of diabetes. A history of gestational diabetes puts a lady at higher risk for developing diabetes later in life, as does hypertension, not just in females, but in males as well. So hypertension is a risk factor for developing diabetes. So these are the classifications I want to briefly touch on, and I will, there's a couple of these that we will, namely type 1 and type 2 are the ones that we're going to focus our attention on. Once the diabetes has manifested, it's going to typically manifest as one of these two and generally fall in the same treatment regimen as type 1 or type 2, with perhaps some minor variations. But type 1 diabetes, these are clear delineations to begin to make. So these top two right here, top two bullet points, are worth committing to memory. Type 1 diabetes is about beta cell destruction. So in this case, the patient is losing functional beta cells that produce insulin. So type 1 diabetes is associated with a lack of insulin production. It's an important connection to make, lack of insulin production. So this then emphasizes what I said earlier, that hyperglycemia is a manifestation of the condition. It's not a sugar problem. It's an insulin problem. And in this case, with type 1 diabetes, the issue is they're not making insulin. They're not producing it. Type 2 diabetes is different. They may have decreased production. Notice I said decreased, not beta cell destruction. So they may have diminished production or insulin resistance or a secretory defect. In other words, they may be producing it but not sending it out of the pancreas. They may be producing it and the organs are not responding, or they may have decreased their production. Type 2 diabetics are still producing insulin, just not enough for it to be sufficient to manage their glucose. So those distinctions between type 1 and type 2 are critical. Again, it's an insulin problem. Either there's not enough with type 2, there's not enough, it's not getting out, or it's not effective. The insulin itself could be mutated. So again, the type 1 and type 2 diabetes, it's not a sugar problem, it's an insulin problem. Sugar is the symptom. So and the same is true of the other diabetes as well, but these are some of the other types, genetic defects, so different mutations in the pancreas, in insulin, in the beta cells, in the island of Langerhans, defects in insulin action. So perhaps insulin is produced, but that insulin that is produced is not, it has mutated or has insufficient proteins to elicit the response that insulin should elicit, and it's related to genetic expression. There's also a condition called latent autoimmune diabetes of adults. So this is a later evolution. It's kind of an expansion of type 2 diabetes, but there's been enough of it to kind of identify it as its own class. Diseases of the exocrine glands, diabetes could be drug-induced because of effects on the pancreas or other organs. Infections such as cytomegalovirus or Coxsackie virus could also precipitate. And then other syndromes such as Downs, Klinefelters, and Prader-Willi are all types of diabetes that manifest, again, from a generally a genetic type origin. And then you have, as I mentioned earlier, gestational diabetes. So for the next portion of our lecture here, we're going to shift to what is the function of insulin. What does insulin do? So its primary job is the metabolism and transport of glucose for energy, but that's not its only job. That's one of its jobs, but it's not its only job. So it is important to understand that insulin is secreted in response to consumption of food or food type substances. Like a protein drink or meal replacement or something like that. So in the process of consuming nutrients, insulin is secreted from the pancreas and inhibits glycogenolysis and also inhibits gluconeogenesis. So that said, those processes are the processes by which glycogenolysis and gluconeogenesis are the process by which the liver produces ultimately glucose in a fasting state. So when we are between meals for a sufficient amount of time, the liver will supplement our glucose needs by initiating glycogenolysis and gluconeogenesis, and both glycogen and glucagon facilitate this process. So what that does then is stimulates the storage of glucose in the liver and muscle as glycogen. Glycogen is a form of sugar that gets stored in the muscle for the muscle to have immediate energy. And then excess glucose that's not consumed or stored by the muscle or used for energy in the present situation, glucose then gets stored in the liver. And that's where gluconeogenesis takes it back out of the liver when we need it, turn it back into sugar. So insulin stimulates glucose storage in the liver, glycogen storage in the muscle, and it inhibits gluconeogenesis and glycogenolysis. It also signals the liver to stop the release of glucose, so this is related to the gluconeogenesis. It enhances the storage of dietary fats into adipose tissue, and then also accelerates amino acid transport into the cell for DNA replication and cell production, cell replication, and that sort of thing. It also facilitates the movement of potassium into the cell. If you remember from our conversation earlier about electrolytes and fluids, potassium mainly lives inside the cell. When potassium needs to get into the cell, there has to be insulin to facilitate that movement. So insulin facilitates the movement of potassium into the cell, as well as amino acids for protein and DNA synthesis. This picture is just a cartoon schematic to kind of give you an idea of this interplay of what I was just describing between the pancreas, the liver, and muscle and brain, and the presence of food and insulin and glucagon and glucose production. This shows you this dynamic between those organ systems that we were just discussing. So it's good at this point to start familiarizing yourself with how these different interactions occur and how they respond in how they manifest in response to food. Now, this slide begins our conversation about type 1 diabetes and how type 1 diabetes develops. So there's a great deal of content on this slide, so I'm going to take some time to explain it. So what you have here is you have time in years on the bottom, and you have beta cell mass, or the number of beta cells that a human has over time. So obviously you see the number 100 there, which is 100%, and then 50 represents 50% of beta cell mass, and then 0. The bottom axis there shows time from birth and then through adulthood. Notice there aren't numbers on here because this varies between patient populations, between individuals. The time for the manifestation of this varies and can be precipitated by different events in an individual's life. And I'll explain as I go further. So at birth, we're born with approximately 80 to 85% of the beta cells that we'll have in our lifetime. And then early in life, we develop the remainder after we're born. So early in life, we have, barring any unforeseen catastrophes or some big challenge to our livelihood, such an example would be if someone has a birth defect and has to have surgery early in life. That's a huge immunologic trigger early in someone's life. So setting those things aside, assuming fairly normal health at birth, within the first early portion of life, the baby's going to develop their full complement of beta cells. So notice the green line goes up to 100%. In the patient population that are genetically predisposed to the development of type 1 diabetes or other genetic forms of diabetes, the patients have 100% of their beta cell mass for a period of time. Now, that period of time could be 2 years, 5 years, 10 years, and is difficult to identify how long it has been because of when the patient ultimately manifests with symptoms of diabetes. So what the green line depicts is that the individual has developed all of their beta cells, they're functioning as normal, and then at some point in their life, they encounter an immunologic trigger. I'll come back to that in a second. They encounter an immunologic trigger. When that happens, they begin to lose beta cell mass, and that's what's depicted by the downward slope of the green line here. Once again, that slope can vary from individual to individual. This looks like a fairly steep slope to me on this depiction. So it's entirely possible that this could be over the period of a year. It could easily be over the period of 10 years. Again, that depends on the time frame. If it's over 10 years, that would mean it's really a more gradual slope than it appears. Some patients, because of an immunologic trigger, can have a very precipitous drop. In other words, a very abrupt drop in their beta cell production, and within a very short amount of time manifest with symptoms of diabetes. So what you see as the green line begins to slope downward, we have a progressive impairment of insulin release. This is a result of this progressive loss of beta cell mass. That's what the green line decreasing is telling us, is that this individual over time is losing cell mass. When an individual drops to about 20% of their cell mass for beta cells, that's when they will manifest with symptoms of diabetes. When they actually manifest with overt diabetes. That's what the slide depicts here, because you'll see the cross section of 20% cell mass. When they meet that, the individual continues to lose cell mass, but at that point, they have overt diabetes. Now, as this slope decreases, as it moves from 100% to 90 to 80, 70, 60, 50, then over time, different symptoms may develop. And as you will see in subsequent material, those symptoms can be very oblique or very non-specific and not necessarily clearly indicative of diabetes. And it may not be until the individual has less than 50% cell mass that they begin to give any hints of being pre-diabetic. So let me back up a minute and clarify what I mean here by immunologic trigger. An immunologic trigger is quite broad in that description, and the definition is equally broad. It is any challenge to an individual's life, body, this organism that is their human body. Any challenge to that organism that may require some form of stress or immune response. So this could be an automobile accident. It could be a surgery. It could be an illness, whether it's viral, bacterial, or a microbacterium, or any other type of immunologic insult. It could be an autoimmune issue that evolves. It could be a whole variety. If you think of any healthcare condition out there that could put somebody in the hospital, that's really what's meant by an immunologic trigger. And what's puzzling about this is we may not know when the patient manifests with overt diabetes, we may not know what that trigger was. And this is what makes it challenging to know what caused my diabetes. But in this case, we're talking about type 1 diabetes, which means the patient has a genetic predisposition. And as I mentioned before, they're losing beta cell mass. And as I mentioned earlier, suppose, for example, that a family gives birth to a child who has a patent ductus arteriosus or a ventricular septal defect or transposition of the great vessel, something that requires cardiovascular or major surgery within the first month or two of life. If that's the case, that could be an immunologic trigger that activates this genetic predisposition. And so this baby could easily develop type 1 diabetes very early in life because they may not have even gotten to 100% of their beta cell mass, and already they begin to lose beta cells in response to this immunologic trigger. So this is what we know so far about type 1 diabetes and its causation, its evolution. So to recap here, type 1 diabetes is when insulin producing beta cells are destroyed, usually as a response to some kind of immunologic response, which elicits the response of cytokines, TNF alpha, interferon, interleukin, those type of cytokines that we talked about earlier in the respiratory section that mediate inflammation. They actually produce a detrimental effect on beta cells and begin to destroy them. So that then results in decreased pancreas function of the pancreas to produce functional insulin. Obviously, you've got fewer factories. You've got fewer cells that can make the insulin that you need. So you're going to have less out there in circulation. Then glucose can't be metabolized, and when it does, it's going to be stored in the liver as fat. That's going to be consistent with people with this genetic predisposition, such as human leukocyte antigen, autoimmune conditions, as I mentioned there, and then other environmental factors. That then results in you have decreased insulin production, unchecked glucose production by the liver because the cells are sensing the absence of insulin because it's not getting in. So in that case, or the absence of glucose, the liver says there's no glucose out there. We need to make it because insulin's not moving the glucose into the cells for the cells to be nourished, which produces the fasting hyperglycemia. That affects about 5% of the population out there that has diabetes. Again, 5%, which means 95% of the diabetes that's out there, roughly, give or take a few percentages, roughly is type 2 diabetes. So the things to take away here is type 1 diabetes, beta cell destruction. You don't have to know that TNF alpha and interferon, interleukin, those kind of things are the ones that do it. You just need to know beta cell destruction. Decreased function of the pancreas. So the pancreas is not making insulin sufficient for the glucose metabolism that's out there. The liver, even though there's glucose in the bloodstream, the liver can't recognize that because it gets its messages from the cells. The cells tell the liver we don't have enough insulin, or excuse me, we don't have enough glucose. They don't have enough glucose because it's not getting from the bloodstream into the cell. That's because of the absence of insulin. So the liver starts making more glucose, which produces the hyperglycemia that we alluded to already. So we'll hit the pause button here and we'll pick back up and cover more with diabetes in the next video.